Good. Well, good afternoon, folks. It seems like I was just with a few of you yesterday, or maybe we were, that we are pleased to have this presentation this afternoon of the U.S. audit. As many of you know, I mean, the audit itself is the most widely used alcohol screening tool in the world, and we were fortunate over the last several years to be able to participate and support in the development of a guide targeted to the use of the U.S. audit, and so that I think that this is fortuitous as it's getting increasingly adopted in a number of ways. Our presenters are two of the developers. Many of you know Dr. Tom Babor, who is at the University of Connecticut and has been working both nationally and internationally on alcohol and other drug issues for many years. Collaborating with him on this presentation is Catherine Kate Rubiani, who is also at the University of Connecticut. And with that, I'm going to just turn this over to Kate and Tom, and they can do some further introductions if they would like, or we will just get down to the business of the webinar. So it's all yours, folks.
Okay, thanks, Joe. And thank you, SAMHSA, for sponsoring this webinar. I think it's a good opportunity to introduce the U.S. audit and to explain how we got to this point, and to get your reactions to a relatively simple training workshop that we will conduct in the next 45 minutes or so. So the U.S. audit is basically an adaptation of the WHO audit, and this webinar is designed for multiple purposes. For the most part, it's to introduce people to this modification of the existing instrument, but it can also be used to train health, medical, and social service professionals to conduct screening and brief intervention and referral to treatment. And many of you are likely to have experience in SBIRT and probably don't need another workshop, but you may want to participate just to figure out how the information communicated here could be used if you want to train other people. We're also going to include an orientation for program administrators. And it's often good to include program administrators in training for an audit or another screening test, so they understand what's going on with patients, and they can help to mobilize resources in order to get screening, brief intervention, and referral done. The fact is that one of the biggest problems or challenges faced in screening and brief intervention is not the patients, but it's in the healthcare system itself. Getting the screening test introduced into a medical setting, getting people to use it, figuring out how you score it and how it goes into the medical record. All of these logistical issues are very important. So the objectives are how to use the U.S. audit, how to score and interpret it, how to conduct a brief intervention, which we'll try to present in a relatively simple way because we don't need high-power psychotherapy technology in order to deliver it, and how to refer patients. And then we'll talk about setting up a screening program. So the first thing to emphasize, which is often lost in translation, is that we're dealing with two populations. And the audit was developed, in fact, to expand the purview of public health and medical management of what at the time was called alcoholism or alcohol dependence, to extend that from the chronic alcoholic who presents enough problems for emergency departments and healthcare settings, but to expand it to include people who might come into a problem with alcohol through social drinking. And even if it's temporary, they are subjects for risk and management so that they don't drink above recommended limits. And if they're above the recommended limits, we want to find out if they are drinking in a harmful way prior to the development of dependence. So the audit was developed for both of these populations. At-risk drinking is the one which is encountered most in primary healthcare settings, and it basically boils down to too many drinks on one occasion, so people are impaired in terms of their decision-making, their judgment, their personality, their behavior, and their psychomotor coordination. And the second thing that the audit was designed to pick up was the number of drinks that is consumed over a period of time, whether it's a day or a week or a month, that would lead to the development of chronic health problems like hypertension or cardiovascular incidents or dementia. So for the most part, we're dealing in risky drinkers with injuries and unintended consequences, unplanned pregnancies, motor vehicle accidents, violence, falls, drowning, and the long-term risks are psychiatric disorders and chronic health conditions. Within the United States, we've gone through a long period of sorting out what is moderate drinking, what is risk drinking, and what drinking guidelines should be recommended in primary care. And we've got general consensus that for women and men over 65, more than 7 drinks a week puts those people at risk. For men, it's a little bit higher on average because of sex and because of body mass and body weight, but for men, it's more than 14 drinks. And on a per occasion basis, risk really starts to accelerate with greater than 4 drinks for men and greater than 3 drinks for women. So one of the things about the US audit, which we attended to both in its initial development and certainly with the modifications in the WHO audit, was to adapt the audit to the US guidelines. And the audit, as you know, was developed for international use, so the questions were formulated on a generic basis as they applied to people around the world coming from different cultures and different drinking patterns. The audit itself and the guidelines that are proposed for scoring have been more or less validated through psychometric analyses and original research, epidemiological studies in many different countries. And we know now that it can be used as an interview and a questionnaire, and we have to be cautious about over-interpreting the results particularly when we have more simple versions like the Audit-C, because there's a tendency just to use the audit alone without follow-up and diagnostic evaluation. All of this suggests that the audit needs to be adapted to the situation in which it's used, and the generalizations that are presented in the manual always need to be adapted to local circumstances. The audit has been the subject of psychometric analyses which have attempted to reduce the number of items, and a number of variants have been developed with different combinations of items. The most popular version is called the Audit-C, and it consists of the first 3 consumption questions. The sensitivity and other test performance characteristics seem to be similar, but there's a tendency to use this as a standalone screening instrument when in fact it probably would be best as a pre-screen, because it doesn't allow for more systematic evaluation of the harmful use and dependent symptoms that are in the full audit. And it's not adjusted for U.S. drink size, which is the issue that motivated the development of the U.S. audit. So that brings us to the U.S. audit. And several years ago, SAMHSA expressed an interest in having an adapted version. It was something that John Higgins Biddle had worked with CDC on in order to get them to develop a dissemination guide for the audit, and in the process, he helped to develop an adapted version of the WHO audit. In many respects, this should have been done a long time ago, because the original WHO audit manual recommended that each country adapt the questions, particularly the first 3 questions, to the standard drink sizes that are most prevalent in that particular country. So with the U.S. audit, we did it with the first 3 questions, and the WHO audit was based on the assumption that 60 grams was really the red line, the threshold for serious drinking, but the drink size that was adopted by WHO to get to those 60 grams was one that was prevalent in Norway and the UK and some other European countries, which was a 10-gram drink size, as opposed to the US and a number of other countries which have a standard drink of 14 grams. So what should have been done, and what has been done in some countries, is just to adopt the first 3 questions to US standard drink size. And these modifications in the US version of the audit will help to allow us to not only make the first 3 questions more appropriate for getting a risk score, but they also help us when we extend the scale by for the first 3 questions to get a precise estimate of the number of drinks per occasion that a person is drinking, so that we can give them advice about whether or not they are drinking beyond the recommended limits proposed by NIAAA and other expert groups. So what we now have then is a slight modification that allows us to estimate whether somebody is drinking at risk in general, but more specifically, risk defined by the NIAAA guidelines. And we can then have both a U.S. full audit and a U.S. Audit-C based on the modified first three questions. That can be joined to questions 4 through 10, which cover dependent symptoms and harmful alcohol use, and those questions are the same as what is found in the regular WHO audit. So why screen using the U.S. audit? Well, it provides an opportunity to start a reflexive discussion with the patient about the implications of their drinking. And that was the purpose of going to 10 questions in the first place, to cover risky drinking, dependent symptoms, and problems so that enough information could be provided relatively quickly to allow a clinician to provide feedback to the patient and to open up a short discussion about their drinking and to motivate the patient to change their drinking behavior or try to maintain abstinence or to get the patient to consider referral for diagnostic evaluation and treatment. It is also important to have this kind of information to make sure that the person's presenting symptoms are fully diagnosed in light of their drinking history and their drinking patterns at the time that they come in for treatment. So if somebody's being considered for a diagnosis of depression or a diagnosis of hypertension, or they have other conditions that require medications that are likely to interact with alcohol, these are all reasons why a good assessment of a person's drinking and their risk levels needs to be conducted. Obviously, the regular assessment through a screening test of a person's drinking provides a good opportunity in the future to maintain surveillance of the patient's drinking so that it doesn't get out of hand. So we know now that the audit and by extension the U.S. audit can be self-administered in a questionnaire or can be delivered in an interview. And that depends on the purposes of the screening, the resources in the facility, and a lot of other questions that need to be sorted out. But there are advantages to both approaches, with a self-administered questionnaire taking less time, being easy to administer, and being incorporated easily into computer administration and scoring. And in some cases, it is likely that a more anonymous self-administered questionnaire would produce more accurate answers. The interview has the advantage of clarifying ambiguous answers, being adaptable to the electronic medical record, and providing seamless engagement between the questions that are asked and the initiation of a brief intervention. So I'm going to turn things over to Kate Rabena, who's going to walk you through how the U.S. audit would be administered in a typical clinical situation.
So the U.S. audit questionnaire comes with an introduction shown here, but it can be modified to suit agency needs or circumstances. but it should stress universal screening. So you want to explain that you ask all patients these questions so the patient doesn't feel like they're being targeted or singled out. You want to stress confidentiality. You want to highlight why you're asking the question. So say that alcohol affects many aspects of your health and can interfere with certain medications. And it's also helpful to explain what you mean by a standard drink, either by using a visual aid like on this slide or by providing the patient with a brief explanation. Before I was trained in SBIRT, I could have sworn that every bottle of wine had three drinks, but actually has at least 5. And so a lot of patients and a lot of the general population aren't aware of this. So if you can explain this information up front, get much more accurate responses for the screening. So here's a copy of the US audit. It's also in the appendix of the manual that was sent out prior to the webinar. The audit can be used without permission or cost. Consists of 10 questions. So as Tom mentioned previously, the first 3 questions ask about consumption. Questions 4 through 6 get at possible dependence. And 7 through 10 are asking about alcohol-related harm. So if you're administering the audit in an interview format, you want to make sure you read the questions as written, clarifying any questions the patient doesn't understand. And I won't go through all these questions because I think folks are pretty familiar with the audit unless people have specific questions at the end. So a 2-stage screening process can make the US audit much more efficient. So you can use the first 3 questions as a pre-screen. So if the patient answers never to question 1, which asks how frequently they consume alcohol, you're all done. If the patient responds to question 2 that they drink 1 drink when they drink and they never engage in at-risk drinking, you're done. But patients who score positive on the first 3 questions should complete the remaining 7 questions. Scoring the US audit is it's very simple. So each response is scored using the numbers shown in red at the top of each response column. So then you would just write the appropriate score in the right-hand column and add them all up to get your total score. So for women scoring 0 to 6, that places them in zone 1, and they're at no or low risk for possible alcohol use disorder. For women getting scores of 7 through 15, or men scoring 8 through 15, that places them in zone 2, which is indicative of hazardous use or a possible mild alcohol use disorder. Scores of 16 through 19 places the individual in zone 3, which may mean a moderate alcohol use disorder or harmful use. And then scores 20 of above or zone 4 are indicative of a moderate or severe alcohol use disorder or alcohol dependence. So for those that are in that zone 1 or that no or low risk range, which would be the majority of patients if you're screening, if you're doing universal screening, would just get feedback. So you would just want to give them feedback about the results of their screening test. If they are current drinkers, you want to just remind them of the NIAAA low-risk drinking guidelines and give them congratulations and pat on the back and send them on their way. For those scoring in Zone 2, so that's the blue, which is indicative of at-risk use, you're going to provide a brief intervention, which I'll talk about in a couple minutes. For those that's scoring 16 through 19, which is harmful use, you're going to do a brief intervention and maybe try to encourage them to accept a referral for brief outpatient treatment. And for those scoring 20 or above that are likely dependent, you're going to use your brief intervention to try to encourage them to accept a referral for further evaluation and treatment. So we'll go through a sample patient quickly. So this is Miriam, who's come to the clinic complaining about digestive issues. She also has a history of high blood pressure. We ask her the first 3 questions. We find out she drinks a couple glasses of wine on weekdays, more on weekends. She's drinking, and a couple days per month, she's having 4 or more drinks. And so now we know she's scored positive on the first 3 questions. We're going to ask her the remaining 7. We learn that she's missed a meeting due to a hangover once in the past year, that does not drink in the morning, has not experienced guilt. She fell down once when tipsy. No one's expressed concern. So her completed US audit would look something like this. You can see, a responsive daily and the corresponding score, and so these get put in the right column and added up. So she has a 16, which puts her in this harmful use category. So we would do a brief intervention and using your clinical judgment, perhaps a referral to brief outpatient treatment. So a brief intervention is a low-intensity, short-duration conversation. It can be, really brief, about 5 minutes. Maybe it's longer if you have to negotiate a referral. But the goal is really harm reduction, so you want to reduce alcohol consumption, facilitate treatment. Brief intervention relies on screening data, and also makes use of brochures, is also brochure driven. Some of the elements included in effective brief intervention are to present the screening results, to provide feedback on the risks and consequences, and when all possible, you want to tie this into the patient's presenting problems. You want to provide clear medical advice about the low-risk drinking limits, solidify patient commitment, and provide advice and encouragement. So here is an example of a brochure that can be used to help you guide you through a brief intervention. So you just provide feedback saying, Miriam, can I talk about your results with you? You were in the moderate risk category, or Zone 3, which means you're at moderate risk of problems related to your current pattern of drinking, including digestive issues and high blood pressure, which are the reasons for your visit today. As your medical provider, I recommend that you quit or cut back. You would review the recommended drinking limits, which for women are 1 a day or 7 per week, or no more than 3 per occasion. And you also want to review with her the definition of a standard drink. You can also provide information and assistance in cutting back, and give this to folks to take home with them and offer your help in the future. For those that need a referral to treatment, so those with more serious signs of alcohol use disorder, or that would benefit from brief treatment, or perhaps medication-assisted treatment, you want to use your brief intervention to try to negotiate with the patient to accept a referral. We know that the earlier patients are engaged, the better the long-term outcomes. We also know that non-treatment seeking cases can still be effectively engaged in treatment, and attendance at first appointment is 10 times higher for referred cases relative to unreferred. So to negotiate a referral, you want to convince the patient of the need for treatment, get permission perhaps to include a partner or family member. You want to determine the level of care and always aim for the least restrictive setting. And you want to be familiar with community resources so you can strike while the iron is hot, so they say. So you want to know, places that take the patient's insurance, that have an open bed available, and you want to do all this while you have the patient and before they change their mind. You can provide support while the patient is waiting placement, and reassess after treatment. And we recommend that the US audit be used on an annual basis.
So picking up now on the clinical side here, the US audit is used pretty much the same way as the WHO audit. The scoring hasn't changed too much because the cutoffs really come very close to what was originally proposed when the full audit was designed. And the most important thing at this point has to do with setting up a screening program in a healthcare facility that is going to routinely screen patients at risk. And the Centers for Disease Control have developed a planning and implementation guide which recommends the use of the US audit as well as other screening tests in this kind of program. I'd refer you to it because it provides, I think, a useful way to get program administrators to appreciate the value of a regular embedded screening program. And in order to set up that program, a number of questions need to be answered. And the answers to these questions will help you to determine whether you want to use a shorter version like the USAUDIT-C or the longer version, or both, in the sense that the US and the Audit-C both allow one to skip out if a given respondent doesn't meet the minimal criteria for being at risk. So many patients don't drink enough for them to get past the third question if they answer that they not consumed more than 3 or 4 drinks on an occasion, and if they don't drink on a regular basis. So the questions that need to be answered start with which patients will be screened. Are you going to screen everybody in the clinic, or is there some selection that goes on prior to the patient seeing their provider. But that needs to be sorted out. Another question is, how often will patients be screened? Generally, it's recommended that they be screened at least once a year. But if a patient is positive, there might be more frequent follow-ups. How will the screening be coordinated with other activities? So when the patient comes in for an appointment, is the receptionist going to pass out the screening test, or do they wait until the provider is taking the patient to an examination room or a waiting room? Who's going to administer the screen? It could be a receptionist, it could be a nurse, it could be a doctor. It depends on how the particular facility functions, who's in charge, how it works, but the audit is flexible to be administered in a variety of different conditions, including computer administration. What provider and patient materials will be used? Kate just went through the use of a brochure to guide the intervention. You would need another self-report form or an interview or a card to guide the patient or the clinician in presenting the questions. Who's going to interpret the results? They can be scored by a receptionist or by computer, but somehow they need to get into the hands of someone who is trained to provide a brief intervention. And then they need to get into the medical record. And the program itself needs to have a plan to decide how follow-up actions will be taken. A list, for example, of referral sources can be provided to the patients. How will patients who need screening be identified? And that's another question. If it's an interviewer who's doing this and there isn't enough time to interview everybody in a waiting room, there needs to be some selection criteria. All the sequence of actions need to be described in a flow chart, and the instruments and the materials need to be stored and distributed, and the follow-up schedule needs to be developed. If a program administrator and the other people who manage a clinic or a healthcare setting go through this list of questions and negotiate how they're going to conduct their screening program, depending on the resources that they have, they should be able to come up with a workable plan. And again, I refer you to the CDC guide, which goes through these steps in detail in order to set up a program. So in conclusion, the audit has become one of the most widely used screening tests in the world. It's easy to use, and it's brief and generally free of cultural bias. It can be used as part of a public health program, not just a clinical intervention, to reach large numbers of people in healthcare settings, to educate even people who are not at risk. It can be helpful to get family members to talk to their healthcare providers about somebody they're worried about. And it provides additional advantages in the form of the US audit because it conforms to the NIAAA low-risk guidelines. So with that, we're going to stop, and hopefully you'll have some questions which we can clarify. And if you have suggestions on how we might improve this presentation and how it can be used for other groups, we'd appreciate it. If not, we thank you for your participation.
Thanks, Tom and Kate. I am going to unmute the lines.
Listen to music and the arts. Explore beauty and truth through artistic excellence. Supported by collaborative community. Complete your college degree. APU's on-campus and online bachelor's degree completion programs can be finished in as little as 10 to 15 months in areas like nursing, teaching, and leadership.
All right, sorry about that. Does anybody have any questions for Tom and Kate? We had a question in the chat box from Sandy Sackerman, and she asked whether the U.S. audit can be used in a social detox center.
Can the U.S. audit be used in a social detox center? One of the things that we've learned from almost 30 years of administering the audit to different populations is that it's not only useful as a way of getting the threshold from low-risk drinking to moderate-risk drinking, but it also represents, when you add up the scores, whether it's the first 3 questions or all 10 questions, but it's also a way of estimating the severity of an individual's alcohol involvement. It covers symptoms, it covers problems, it covers the amount that somebody's drinking. And you put all those things together, and what you're going to find at a social detox center is that when people come in, they're likely to be way above the threshold, even at high risk, which is generally a score of 20 or more. But between 20 and 40, or in the U.S. Audit, it goes up to 46, you're going to get a lot of variability. So some people who need treatment, they need a self-help group, they need to be guided through detox, are going to be, scoring around 20 or 25. Others are going to be up to 40. And there is a difference between people at that end of the spectrum. So the answer to your question is yes, it can be used at a social detox center as an overall severity measure, and my guess is you're going to get just as much variability at that end, which is true variability, that some people are much more severely alcohol involved because of their severe dependence, their severe problems, their high consumption, and other people are going to be at the lower end of that spectrum. And that's useful to pay attention to, because the audit can be used as an instrument that measures the severity of somebody's alcohol dependence, their alcohol involvement.
Great, thank you. Any questions from anybody on the line? We have a few more via the chat, but wanted to open up for people to ask as well. If you're on mute, just remember to unmute yourself. Does anybody want to jump in with a question, or I'm happy to read the chat one? All right, let me go to the chat. We had a question about how well the U.S. audit pairs with the universal audit question as a pre-screener versus the audit-C.
That research hasn't been done, but since it's not much different than the regular audit, my guess is it's going to be pretty much the same. And the universal screening question is what? How often have you had how many drinks? Can you remind me what the universal screening question is?
Let's see, that was from Austin Ralston. The universal screening question, how many drinks? Is anybody on the line have that handy?
Yeah, it's how often men have had 5 or more drinks, or how often women have had 4 or more drinks on an occasion.
So my guess is that the audit's going to be pretty good at that, because the third question is designed to measure exactly that. And if you want it, I mean, that's it. So
that universal screening question really only gets at if the person is binge drinking, so it catches that pattern of drinking. But if they're drinking, not engaging in binge drinking, but if they're drinking too much per week or going over their daily limits, that universal, if you only ask that question, you miss that population of drinkers.
And one example of that would be a woman who maybe has 1 or 2 drinks a day, which might not be picked up on the third question, which is the universal question about acute risk, but she would be at risk of breast cancer because that risk starts just a little bit above 1 drink a day.
Great. We had a few more comments and questions in the chat box. I can share those with you. One comment and question is, one of the impediments to advancing robust alcohol screening and intervention is lack of a well-validated outcome variable. What would you think of using the U.S. audit with a different time delimiter? Do you have any plans to validate a form of the audit as an outcome measure?
Yeah, the audit has been used in a number of studies as an outcome measure, but you need to adjust the time frame to make sure that the time frame that's used when the audit is first administered is the same as when it's re-administered. And if you have a 1-month follow-up, but both are using a 1-year time frame, then the results at follow-up are not going to be, they're not going to be useful. So if you want to use it as a change measure, which I think is perfectly acceptable, you need to pay attention to the time frame, both at the first administration and its subsequent administrations. And if you're doing research, you want to probably adjust the time frame accordingly.
I think when John Higgins-Biddle and Tom and others began working on the U.S. audit, something that folks were excited about were, because the cutoff scores are based on the NIAAA drinking limits, false positives are very unlikely, and it didn't really need much of a validation.
Great. We had another question and comment from the chat that said one of the questions that has come up in recent SBIRT training was related to U.S. Audit Manual. In that manual, on Appendix C on page 20, is a recommendation that women not drink at least 2 days of the week. That's the first time I had seen that and wondered if there was to support this statement.
So can you repeat that? The last sentence was garbled.
Oh, I'm sorry. Yeah, in the manual, the U.S. Audit Manual, and Appendix C on page 20, there's a recommendation that women not drink at least 2 days of the week. Right. And the person commented that that's the first time they had seen that and wondered if there was evidence to support that statement.
You know, that might have been from an older version. I think we had it reformatted later because it looked like it only applied to women, but it was just, I think, meant as just, and I think we had reworded it that,
yeah, that was a mistake that we tried to correct in a subsequent edited version of the manual, but there are in the mistaken version, it applied only to women. But I think the question asked, is there any evidence that it's good to have a few days of abstinence? And I think the answer is the less you drink, the better it is. And the less frequently you drink, the better it is. And that it's always good to have a few days of abstinence during the week if you're a regular drinker, because people getting into a pattern of daily drinking is likely to open up the opportunity for them not only to drink in moderation, but also drink in excess. One of the most common findings across cultures when you look at people reporting on their drinking pattern is that the more frequently they drink, the more they drink in excess. That means that people who drink on a daily basis are much more likely to be drinking excessive amounts on a daily basis. Even though we appreciate the fact that people might take one drink a day and never exceed that amount, the likelihood of that happening is much less than a daily drinker drinking to excess quite frequently. So quantity and frequency tend to be correlated, and that's probably because people who drink on a regular basis put themselves in situations where it's easier to not just stop at one drink, but to go on to more, either because they're going to a bar for their one drink a day, or they're at home and their refrigerator is stocked up with beer, or they are in other social situations which make it difficult to stop at one drink. So it's always good for people not to drink, and the less they drink in frequency, the less they're going to drink in quantity as well.
Thank you. Any questions from anyone on the line? Okay, well, I think that may be all of the questions that we have. Tom or Kate, do you have any additional comments before we close?
Nothing other than good luck in your work, and we hope that screening and brief intervention and referral will continue to expand within the healthcare system. It's been an adventure to get to the point where we're broadly disseminating screening tests and people are beginning to incorporate them into the routine mechanisms that are used to manage patients. And I think it's a credit to organizations like SAMHSA and to the translational leaders, the people who take the research and apply it to get us to this point.
Great, thanks, Tom. And any SAMHSA folks on the line, do you have any closing comments before we close the webinar? Okay, well, I think we'll go ahead and end the session. We did record, and this will be available after the Ideas Exchange, and we'll send a notice out when that becomes available. Thank you, everyone.